It's now 6 o'clock. I think we can start. I'm handing over to Dr. Dix. Thank you, Dr. Dix. Over to you.
Thank you, Renier. Good evening, everyone, and a very warm welcome to this third installment of our MMED Mastery series. My name is Tina Dix. I'm a fellow in clinical hematology, and I will be facilitating this session this evening. So the need for MMED Mastery series hosted by SARA, which is the South African Registrar Association, was really born from a need that was discovered in the end of the year 2023, when we ran a survey among registrars, and we found out that there are lots of gaps that prevent registrars from effectively doing research. In order to address these gaps, we started the MMED Mastery series, which had its first run in 2024 and was well acclaimed and very well attended. And we like to think that it really helped some of the registrars finish their research and able to get on with the rest of their degree and their exams. That culminated in a writing retreat where registrars came together in Gauteng, where specific emphasis and training was given on how to finish your MMED thesis. So this year we're continuing the trend. We've had 2 webinars already. If you haven't watched them yet, I implore you to do so, but for tonight, we are going to be looking at a bit more into data analysis and data methodology. So to start us off with, I'm very happy to welcome Dr. Tijol Morar. She is a consultant psychiatrist with a very well-decorated CV. She won the Lynn Glennis Medal in 2018, as well as an Avantis Medal in 2021 for the fellowship examination of the CMSA in psychiatry. She's currently pursuing a PhD. She's also is supervising a number of MMED students. So I do think she knows what she's talking about. And in tonight's session, she will be talking to us a little bit more on key aspects of biostatistics, statistical analysis that you might need in your MMED protocol. Dr. Morar, thank you so much for joining us. Over to you.
Thank you so much, Tinas, for that lovely introduction. It was very flattering. I'm not sure if I do know exactly what I'm talking about, but so as Tina said, I'm a psychiatrist and I have a special interest in research. So I've kind of decided to pursue it full time for the next 2 years. So it's quite interesting. I only have 20 minutes, so I'm not sure how much I can get through in terms of biostats in the 20 minutes. But yeah, I thought I could maybe give you some insights into what I think might help, why it's kind of important to have some working knowledge of biostatistics. So that's a little bit about myself, and I'm also affiliated with ADASA, which is the Academic Doctors Association of South Africa. So if any registrars are interested, please join us at ADASA, because I think that we don't realize kind of how much support I think academic doctors in South Africa need. And even from a registrar point of view, you can provide a lot of that. So your experience is so valuable. So that's a little bit of advertising from my point of view. But getting straight into the presentation, because we don't have that much time, I've got a quick introduction. I want to share what kind of resources I used, and then we've got a small emphasis on sampling and then the basic outcomes of different study designs. Okay, so why is biostatistics important? So I know a lot of registrars say that they would preferably just pay someone to do their stats. And unfortunately, I've had some candidates, MMED candidates, who have paid people and then they still don't really receive what they need. So yeah, statisticians have the perhaps technical knowledge, but as the candidate, you really need to know what you need from a statistician. And also clinically, we have knowledge that statisticians don't have. So the way they interpret the data may not be what you have, your research questions. They might not be answering your research question. And for me, it's just kind of heartbreaking to see people pay thousands of rands and they don't get what they need at the end. So I think that's why it is important to have some sort of working knowledge of biostatistics. So the next is that it is a requirement to register with the HPCSA as a specialist now in terms of your MMED. And that includes then, kind of there's an assumption if you have an MMED that you do have basic knowledge around statistics. For us and in our I know each department is different, but in psychiatry is part of our CMSA exams, our part 1 and part 2 exams. We often get questions. They might be multiple choice questions or even OSCE questions on interpret the study. So that's why it's important as well. It also translates into patient care when a patient asks you, what are the chances this treatment will work for me? They do require some sort of, kind of technical answer around that. So it's not where the biostatistics is far removed from patient care. It's a big part of how we explain things to our patients. Also, being a global specialist, I'm sure if some of you have had the opportunity to attend congresses, a lot of it is explained using biostatistics. And yeah, I think it's very difficult to go to a congress and engage with presentations if you don't have some of that knowledge. Also, as a registrar, I think everyone is a joint appointee. It might be with different universities, but one of the academic responsibilities will be around supervision. So it's tricky if you've had someone do your stats for you and then you graduate and next minute you're supervising someone and you are required to give them some guidance around statistics. Also, if you want to move up the academic ladder in terms of staffing and promotions, it's also very important. And I guess interpreting new diagnoses and treatments, you yourself can kind of be at the forefront of that, which is very exciting. If you're seeing in your ward something working that's not in your guidelines, you can do a quick study and compare different groups of patients and see if there's a, statistically significant difference between them. And then so much information is available. So I think we have to know what can be trusted and what can't. Often now, especially in the age of AI, people, I think we need to be a bit more critical in terms of our thinking, and that requires a basic knowledge of biostatistics. So I hope I have convinced you, hopefully not to just pay someone to do your stats for your MMED, but to engage a little bit more with the knowledge. And I know Reg time is very, very busy, but I think it is important to carve away some time to try and understand biostats. So biostats is difficult. Well, for me personally, I found it really difficult. It was just so different from clinical medicine, and I did have this kind of cognitive block against it. I kind of thought it was too hard. But I think so even now when I'm reading journal articles, I still Google the statistical terms and I learn as I go. or I forget, oh, what does that statistical test again? Let me go back and quickly Google. And so it's a continuous process. And I think the more you expose to it, the easier it gets. So I really would encourage you to like, it's not where you can't do it. It's just where I think having a bit more of a growth mindset around it is important. And everyone starts off not knowing a lot about it, because we don't have, whole modules dedicated to biostatistics in medical school. It's usually really just the surface that we are exposed to. So you're not the only one if you think it's completely overwhelming and it's really, really challenging. But the more you expose yourself to it, suddenly terms become a bit more familiar and it's useful. So resources. I don't feel like registrars use their university enough in terms of resources. So remember, you are technically paying fees to the university. A lot of the time it's subsidized because depending on your province, the Department of Health will subsidize the fees for your MMED. But because you are paying fees, you are entitled to a lot of benefits that the university can offer. So use that. That's something I would really recommend is Google your university's biostatistics department. So I did my postgrad at Wits, so I'm a little bit biased in terms of I know that they have some good courses and programs. So if you'd like to even Google Health Sciences Research Office and have a look at some of their courses. If you're not affiliated with the university, though, you might have to pay extra for those. But if you are, then use your university and have a look at what is available at your university. So most universities have biostatisticians employed. So involve them from the beginning of your research. When you're already drawing up your protocol, involve your biostatisticians. You can go to them with your research questions and ask them, how exactly do I do this? Yeah, they, especially in terms of a sample size, they often, you need that for your protocol. So that will be one of the big things. And also the data analysis section of your protocol, you'll need a biostatistician to assist you with choosing the correct statistical tests for your research question. But you need to go with your research question so you know what you need answered. And then research courses, like I said, Wits has a 12-week biostatistics course run by Prof. Jonathan Levine. He is excellent. And yeah, it's even that is scratching the surface. So I'm not sure in terms of 20 minutes how much I can teach you about biostatistics, but it's more around hopefully guiding you to get the resources that you need. And then most statistical software, you actually need to have a license for it. And once again, if you're paying fees, use that because you should be having a license through your university. So I use mostly Stata, and Wits has a software for that. Yeah, I'm speaking, sorry, I didn't maybe emphasize this enough, but I'm speaking more about quantitative research here. Qualitative research is very different in terms of its data analysis process, but I think generally medicine, the majority of what we do is quantitative. But once again, there are people to assist in your university when it comes to qualitative research even. And then your software would be different, something like Max QDA, etc. But Stata is well recognized, it works well. So yeah, make sure that you don't pay extra for these benefits that you should be getting because you pay fees. And then if you don't have maybe you feel like you need a bit more outside of university, Coursera has a UCT course on understanding clinical research behind the statistics. There's edX courses. Wits has one on academic writing for clarity and meaning. And then LinkedIn, I found, has been quite an interesting resource. If you follow PhD candidates or you even kind of search for biostatisticians, they really make it quite a lot simpler to understand. So, yeah, I think it's important. I don't know of anyone who has just mastered biostatistics kind of alone, of like any registrars. I do think it needs, some sort of teaching and support and guidance around it. So that's my kind of advice, is please use your resources. So I noticed on our advert, sampling was advertised. So I just wanted to give you a little bit of a overview around case sampling. So basically, when you're doing research on an entire population, it's too resource draining to kind of sample to do research amongst the entire population. So if you've got like a clinic, for example, there's 10,000 patients registered at the clinic. It's really difficult to collect data on 10,000 people. You don't have time, you don't have the resources. So the idea of sampling is that we would collect data from a select few patients that can be then applied to the whole population. So if you have a small population, say you're studying a rare condition like that has only 50 patients in the clinic that have it, you don't necessarily have to sample then. Then you can say, I'd like to actually collect data on the entire population, the 50 patients, because you have the time and the resources and it is feasible. But generally not. So the reason why sampling is so important is that you have to have a sample that can be generalized to your population. If it can't be generalized to your population, then you essentially are just doing research on the select few. Your sample is all you can comment on. And that's not so helpful, because if, for example, you want to know how many patients in the clinic have a certain diagnosis, and your sample is not representative, you can only report, you can't say the prevalence of this condition in my clinic is X, Y, and Z. You can only say the prevalence of this condition amongst the sample is X, Y, and Z. So that doesn't help in terms of implementing things, and it's also unethical, because now you've gone and done all this research on all these people, but you actually can't draw conclusions that are clinically helpful. So yeah. So this is the different types of case kind of sampling. It can be random, systematic, or non-random. Generally, random is the most reliable. So wherever you can, choose random sampling, and there's different types. So there's simple, stratified, cluster, and multi-stage. But these are all random, and then systematic is a bit more predictable, where a certain member of the population gets selected for the sample. And then non-random, we usually use non-random in more qualitative research, but really it's hard to defend non-random sampling, especially if you're going to publish your research. People will always ask, why didn't you randomize the sample? Because now it can't really be generalized. So that's something to keep in mind. Yeah. Okay, and then in terms of sample size calculation, I see time has already flown by. But I just wanted the idea behind sample size calculation that I wanted to portray is that it's not a simple calculation where I can tell you X plus Y equals Z. This is how, you calculate it. It depends on, once again, what you're trying to find. So if you are doing a descriptive study, you want to know what's the blood pressure of my population or what's the blood pressure of my sample. That's going to be a different calculation to what is my prevalence of hypertension amongst the population. So if you're looking at a descriptive study, it's the standard error of the mean. And then so as you can see, the standard error of the mean is something that we don't have. And this is the sample size, and that's your standard deviation. So you might need to have a little bit of an idea to give to your statistician on previous studies that were done. So say you'd like to know the average blood pressure of your population, you'd have to say to the statistician the standard deviation in previous studies was X, Y, and Z, and that's what they would need from you to calculate the sample size. If you're trying to estimate prevalence, once again, you'd need from previous studies a prevalence rate, or if you don't have previous studies, your study is the first to do this, then you might need a pilot study in order to give that to the statistician to assist. And once again, sorry, I just don't have time to completely go into all of these formulae, but this is basically what you need as the clinician. You need to go to the statistician with. Otherwise, they might use, for example, with estimating proportions, they might use a 50% prevalence rate, just because that's what you do if you have no idea. But it's so far off from what you know the prevalence rate to be. Like the prevalence rate of HIV, for example, is not 50%. It's around maybe 18% or 14%, whatever the case is. So it's so far off. And I think you come with the clinical knowledge of how to do that. Okay, and then basic outcomes of different study designs. So if you have a case control study, you're looking for an odds ratio. If you have a cohort study, you're looking for relative risk. And then if you have a randomized controlled trial, you're looking at a risk difference between two groups or an outcome difference between two groups. So I'm not going to have time to go into these famous tables, but if you'd like to take a screenshot, go ahead. But it's basically how to calculate an odds ratio. And then, so if you see a case control, this often comes up in SBAs and those sorts of things. And then if you'd like to also calculate relative risk, that's the final outcome of a cohort study. I think previous talks have focused on different study types. I'm not going to go into that, but this is quite important. And then if you are evaluating interventional studies like a randomized controlled trial, basically your relative risk ratio is what you're looking for. Yeah, so I know I did fly through these slides, but I hope you managed to take screenshots. Yeah, I hope that that was useful. But I think for me, in 20 minutes, I just wanted to emphasize that there's support available. Use the support. And then as a clinician, you need to know what your research question is. Yeah. Thank you.
Tejal, thank you so much. I really enjoyed that, and especially your first few slides where you lay out what the reasons are for understanding a bit of biostatistics. Not only is it part of your MA degree, but you do find, like, once you're on the other side of the CMSA exams and of the MMED, that all of a sudden it is you who is critically appraising new articles, questions that your patients might have. And it's often striking, things that we get taught and that you just take for the gospel. You realize how thin the evidence is that was actually built upon. And it's only when you understand how to read an article, how some statistical analysis works, that you're able to do that. So thank you very much. Just going to have a look at the chat and see if there are any questions. If there are none yet, I might just quickly ask you, is there any, I know you went through some resources, but is there perhaps YouTube video or maybe use the chatbot or something to just say I'm starting with my MMED. I don't know really where to start. I have no idea about statistics. I just want to get a bit of a foothold in and know what I'm going to, just know enough so I know what to ask my biostatistician. What would your approach be, or do you have any recommendations for someone like that to see odds ratios and want to run for the walls?
Yes, that's a really good question. I don't have anyone particularly that I go to on YouTube, but I often do YouTube. Basic concepts if I don't understand them. But I think when you're starting off your MMED, it's quite overwhelming to kind of think of, especially if you don't have the data on hand, all of the statistical analyses that's to come. But if you have a biostatistician, so for the protocol, the main thing would be probably a sample size calculation, and then speaking to a biostatistician about which tests would fit your data, because your data, it depends if it's categorical data or if it's numerical data, and whether then it's parametric or non-parametric, they will guide you along that. And then once you've got the name of those tests, you can then, I think, then it's easier to YouTube or Google and try and understand the basis of those tests. But it's really vast, so I wouldn't recommend that you go and read up on all the statistical tests that are possible, because it might not be relevant for your data. But yeah, I don't know if that answers your question, but YouTube is a very useful resource. And yeah, sometimes you need to hear it over and over again. So if it's from different viewpoints, it's useful.
Thank you. Thank you so much for that. See in our Q&A, there is a question from Mahlatse Moshabela. Basically just asked, he missed this, the area or the part where he spoke about what support is available. I'm a SAMA member. How do I access support as to what to do because I want to publish my MMED? Mahlatse, so I think this session will be recorded, so you will be able to watch it after the fact if you're part of the recording. Maybe Tijan, is there anything that you just want to highlight that might be of help to Mahlatse?
I would, number one, choose a journal that is applicable, your research is applicable to, because if the journal scope is not what your research is, then you'll kind of get rejected through the first phase. The editor will just reject it. So make sure that that's in alignment. And then I would also say follow the author guidelines as you draw up your MMED. All journals have author guidelines. And then just kind of having a really thick skin about it. You'll realize research is quite subjective sometimes, and one reviewer will say your article's amazing, and the other reviewer will say it's terrible, should be rejected. So you every comment or every kind of feedback will make your research more robust. So just take it as that, not a personal reflection of my MMED, when I sent it through, I got like really, really scathing comments, but in the end it was published. So don't feel despondent that it can't be published. And your supervisors really should be guiding you as well, reading that first draft, making sure there's no big flaws. So yeah, that's kind of my advice around publication.
One more question from Gunza Kamba, who asks, how much is needed for a sample to be more representative of the population?
So once again, it depends on your research question. It's not not like a specific proportion. And then it also depends on the power of your study. So generally we aim for at least like 80%. The power of your study should be 80%. But it's not a simple answer. If she could please maybe speak to a statistician exactly about what her research question is, because that will differ. Yeah.
I find that a nice place to go to sometimes if you don't know where to start is find an article with similar research to what you've done, maybe looking at the similar population, and just have a look at what their population was, what their sample size was that they used. It might be good to go to a statistician and say, listen, I'm doing my MMED, basically I'm modeling it on this article. I want to do something similar, or I like the way they've done this. Maybe you can give some advice. But I definitely agree with you. I think biostatisticians should be able to help you with this, especially in the beginning part, because understanding how much power you need for a study can be a bit daunting, especially if you're just starting out. Kishore, thank you for the presentation. Thank you for those answers. I am happy now to move on to our next speaker. So I would like to introduce Prof. Stephen Machitsa. So he is currently the head of the department in orthopedics at the University of the Free State. And among his many accolades, one thing that he's quite passionate about is outreach work. He's done a lot of outreach work in Limpopo province and was even acknowledged by President Cyril Ramaphosa on a visit in September 2020 with the HPCSA, as well as by Dr. Zweli Mkhize, the former Minister of Health. Prof. Stephen has also been a speaker on previous talks, and we are very excited to hear what you have to say today. Tonight, you'll be talking to us about how to unpack data analysis for your MMED. Prof, thank you so much. Over to you.
No, thank you very much for kind introductory words. So my brief was trying to show you guys what to do with your data, the data that you have collected, and if possible, use the journals that we published. So it's a study on musculoskeletal injuries from gender-based violence at a tertiary hospital that we published in the International Journal of Injury, and then the other one was done by a statistician. So he used the same study to come at another conclusion. So just to kick off, so those are the two articles that we published. And then just to remind you, your MMED research is a collaborative effort. And the statistician is one of your most important members, as the previous speaker has alluded. So there are different kinds of studies, prospective, randomized control, just to name but a few. But the example I'm going to use is a retrospective study, which we did in our case here. Now the pros, and this is what we try and advise from our departmental point of view. The reason being, you are very busy as a registrar, you've got other things to do. So we usually try and advise on a retrospective study. You can do a prospective study, for example, if you have a large volume of those patients and the records are well kept, and you know that to collect the data won't take you more than 6 to 12 months. But in most purposes, registrars will choose a retrospective study. That's got its own problems. The good about them is that they are not expensive, and you can evaluate bad outcomes, and you can also allow analysis of rare conditions. And what is important to me is that it lays the groundwork for prospective study. So if you, like this study, if we do a prospective study, I think we'll get more. The problem with this is that inadequate data collection, depending on the topic you choose. A retrospective study can be very powerful if you've got large numbers. You can even publish it in international journals. If you're going to review a number of patients, I'll give an example, 1,000 to 10,000, or you go 5 years to 10 years, retrospective studies. That is bias. There's something that other authors will look at and learn from that study. So for registrars, it may a little bit be difficult to do a 10-year study, a 5-year study, or looking at about 10,000 patients. But if it's possible, it's fine. So the overview, that of data analysis, is data collection. So we have talked about this. I've even sent Dr. My previous presentation that also had a similar problem, and I think it's time to change the computer. It's about 70 slides on research methodology. So I've sent it. I don't know if you guys managed to get that presentation, talking about when you start, how to start, different types, and some of the things that were covered by the previous speaker are there. So data preparation, data analysis, transform those that data into findings, and then address your research question. Remember that your question can be addressed, can be answered positively or negatively. Or you can do a study, same study that was done by somebody overseas, and then you do a South African context, and you come up with different findings. I agree with the chairperson that he says, get an article, read, then you can get ideas, and then try and see if this study is applicable to a local situation. Because let's say, for example, it's a high-tech study, they've used a lot of technology. It's not applicable in most of our South African public hospitals. So what is data collection? This is a systematic gathering of relevant information to answer research questions. For an example, in our study, as I mentioned earlier, we did a retrospective observational study of 138 patients, 18 years and older. And the records, it was a limited time. So that's the sampling that the previous speaker was talking about. So it's a limited period, January to December. So that's 12 months. And then we looked at variables like demographics, relationship to silent, and then we got a key insight here that was a little bit different from other previously done studies. Female and unemployed, and then this occurred after hours and weekends. And it is just the table that shows some of the findings that we talked about. And the use of alcohol was very significant in these injuries. So we had a data collection form. So you must have a data collection form of the things that you are looking for. And this will be based on your article reviews or on the study that somebody did somewhere there. So if you look at that collection forms, it has a study, the patient study ID number, gender, race, employment, date of injury, time of injury, relationship to assailant, use of drugs, reason given for assault, diagnosis, whether it was bony or soft tissue injury. So this was a collection chart, and you can see there on the right-hand side all those patients, and then you have to complete that for all those patients and what kind of drugs they used. So and then once you have done that, you come to a stage where you do what you call data preparation. So where you clean your data, you organize, as we did that in that table that we just saw there, so that you can analyze it better. So study example, as I mentioned, categorization of injuries. Was it soft tissue or bony injuries? And then you code variables, different variables like substance abuse, gender, injury type. And then how do you handle missing data? Because as a retrospective study, you may find that the patient was not asked about whether they had drank alcohol or they had used substance. So you have to know which data, if you how to handle it. Do you remove it completely, or do you use some of it? So the techniques used, it's a frequency tabulation and transformation for statistical modeling. And I think the previous speaker will tell you more about this. She did mention that statistics is not easy. Every time I have to evaluate a mini thesis, some of these words I have to go and read them again, over and over again. So it's not it's a repetition. And then so now you use statistical method to extract patterns and relationship. For example, we used descriptive statistics. Mean age was 35 years. Or you can use inferential statistics under those different three categories that I've mentioned. A chi-square t-test or multivariate. And then advanced modeling. This was done by the statistician. I must say I read it a couple of times before I could get the grasp of it. As she rightfully said, these are the things that we don't put much emphasis on, maybe because of other needs. So now you have analyzed your data. So you need to transform this into meaningful findings. So that falls under your discussion. So that's when you convert your raw results into insights that inform clinical understanding. The study example, for example, we used a CMP regression model that was done by the statistician in the other study. And then he found that there was underreporting of gender-based violence injuries. And then we, as an example again, defensive injury patterns were observed, especially among women. And I mentioned earlier that alcohol use was significantly associated with injury occurrence with a p-value of 0.026. So what's the implication for this? This highlights the need for targeted interventions and early identification of gender-based violent victims. So remember, you need to address your research question. For example, if we look at this article, what are the patterns of musculoskeletal injuries from gender-based violence? And what factors were associated with those injuries? And our findings were that high prevalence of upper limb fractures are more among female victims. Those are defense injuries. So what it says to you, if you are sitting in the clinic and a woman comes with a defensive injury, for example, a fracture of the ulnar radius, you need to go back and find out if this is not a gender-based violence. You may save a life in that way. And then we also realized that there were socioeconomic factors here that are linked to the injury risk. Unemployment was also an important factor. So what we conclude is that the data analysis provide actionable insight for clinical and policy responses. So what you're saying, as I mentioned earlier, patient comes to the clinic with an ulnar fracture. A lady who's either drunk or either the assailant is drunk, then you know it's most likely a gender-based violent injury. And as you know, by law, we are required to report this kind. So you just simply refer that patient after treatment or during treatment to a social worker. And policy response, that will be societal issues, moral value issues, what's happening in the society, alcohol control. I always give an example of during COVID, we had very few injuries because alcohol was banned. So I'm not saying we should ban alcohol, but it's a significant factor. You don't find this in countries that have outlawed alcohol. So the key takeaway from me is that rigorous data analysis transforms clinical observation into evidence-based findings. And statistical modeling, which was done for the other paper, can uncover hidden patterns in underreported data. And this study exemplifies how structured analysis informs orthopedic and public strategies. And I agree with the previous speaker that your supervisor, you must be very active and will help you as they've gone through the process in your the topic that you choose. In some institutions, for example, we are lucky that you find consultants fighting to have students, especially in smaller centers like us. They want to guide research, and so you've got a lot. So they will choose a topic that they know that will be able to find information, you'll be able to gather data easily. So it's very important that you have a supervisor who's helpful, active. I also advise our postgraduate students that please have two supervisors, the supervisor and the co-supervisor, so that if the supervisor is slow, the co-supervisor will assist you. I hope I've managed to do the briefing that I was allowed to. Okay, I think that's the end of my story.
Rafa, thank you so much for your story. I think it was very nice how you were able to show to us how we can use data analysis in a real world setting to inform what we see clinically and what we should look for. And this just basically tells me again how important it is to do research, especially in a place like South Africa, where we have unique needs and where there's a lack of research in a lot of areas. So thank you so much for sharing that experience with us. I know University of Free State, you refer to it as a small university, but you guys usually punch above your weight in terms of research. So we're very happy to have you here. I don't see any particular questions and answers yet. Questions yet. So if there are any questions, we have a few minutes. Please post them in the chat. Prof, while we're waiting, I might just ask you, how did you start off when you were a young researcher in terms of using statistical analysis methods? What was kind of your approach when you started out? And you've given a few nice examples, but do you have any bits of wisdom for someone who's just starting out and is new to the world of data analysis? Any nuggets of wisdom?
Yeah, I think you guys are lucky that when we started, because you are required to do this course, research course, we were not. You will just have to find out that there's such a course, and it was usually reserved for the consultants. So it started that way, and it meant a lot of reading, especially statistics. And Dr. Morales has rightfully say it's not an easy subject, especially for us who are busy with other things. Got to read it time and again. So that was the first thing. And then the second thing, what I did, I registered for a course on research, a private course. Then I went and attended it. And then when I went to full academic in at UFS, I did attend that course again, the same course that I had attended before, because I knew that, and you have got to keep on reading. Like now, I had to reach the research methodology again, so that the terms are still stay fresh on my mind, because it's not what I teach every day. It's just it's in a while thing that we do. So I think resources, and Dr. Morad mentioned about the resources that they have at the university, and I'm sure other universities have the same things. And I also took a picture of those resources that she mentioned. So I want to lay my hands on some of those resources. I think you just have to keep on looking at it. If you don't understand, keep on reading it until it makes sense.
Yeah, I think that really it's a golden thread that I'm getting from yourself and from Dr. Morar is this is not something that we do every day. It's not something that comes naturally to us. And unfortunately, it is just a case of ABC, apply bum to chair, do your reading, do your due diligence, and then it will become easier. But you have to put in the effort. Dr. Morar also mentioned the benefits you gain from going to a course. So I would also encourage attendees, if that's something that you are interested in, attend a course, learn some of the basic methods, know about some of the more advanced methods. Even if nothing else, it enables you to talk to your biostatistician. I remember with my MMED, it was very difficult for me to get from the university biostatistician what I actually wanted. And I realized that's because I was asking the wrong questions. I didn't know what questions to ask. And it's only after understanding a little bit of statistical analysis myself that we were able to have a conversation and we were able to kind of meet each other halfway. So I think that's also very important for that.
I think it also helps you when you go to a statistician. The statistician doesn't talk above you. I've had situations where I argue with the statistician that this is what I'm looking at, and they're very open. They'll tell you, okay, let's try something else if that's what you're looking for. So it's something that you have to know, and those of us who are in academia, unfortunately, it's something that and the registrars. You can choose to have studies like qualitative. Some qualitative studies don't have statistical analysis, but they're very difficult. Qualitative, most of us are taught in quantitative research. But if you've got a simple topic, you can do a qualitative research and also a prospective study. If it's a simple topic, I'll always give an example of so a simple study. I mean, it sounds like a comic story where an orthopedic surgeon went to compare the power, the grip strength, and the intelligence of anesthetist with orthopedic surgeons. It was a very little simple study, but it was enough for the MMED, obviously, because an orthopedic surgeon, it was biased more. The findings were biased towards more. I'm just giving an example, that you can and do something that is feasible. Choose a topic that is feasible. Because you've got very little time. Most courses are 4 years. You have to make sure you are done within a year. And then the last 2 years, 18 months, you are reading for the finals. You don't want to be burdened down by your research. So that's what I will advise. And the pilot study is very critical. And one of the warnings is with all the ethical committees, when we've had problems in our university, do not talk about the data before you get the. You may have the data as part of your waking. We're collecting data, got files of certain patients, but you don't talk about that to the ethics committee that I already have files for this. They're just simply going to reject your protocol. I hope that helps.
Thank you so much. No, it does. Thank you for those words of wisdom. Dr. Mara, do you have any final thoughts that you would like to add?
No, just thanks for having me, Tinis, and Prof. Matita had some really, really good points. So it's always nice to hear from someone who's experienced. So yeah, I would encourage the registrars to take that one. Yeah, especially what he said about the time period. Choose a small project that's feasible in the 4 years. And remember, it's not all in your control. Unfortunately, you can work hard in 6 months and get everything done, but the ethics committee will take time. Your assessor group may take time to get back to you. The reviewers from journals will take time to get back to you. And then that might even affect your future employment. So I would really say push in the first year or two, get it done, and then you can focus on your part two. So that's very good advice. But yeah, thanks.
Yeah, I agree. It is good advice. Your time is very short. Something that I find with research, you really have to try and keep momentum. It's very difficult if you started with something and then you do something else for 6, 9 months. Now you have to go back to your research. It's very difficult to pick up where you've left off. So hit the ground running, get your MMED done as soon as you can. You want to focus on those exams because they're tough and time is short. I see one question to Prof. from Gunza Kamba. What if the supervisor tends to not have an interest in your topic? Can you change a study design from a study done overseas? Prof, I don't know what your answer to that would be.
So that's why I said my first advice is get 2 supervisors, right? A main supervisor and a co-supervisor. It happens, we know, in PhDs as well. It happens you'll find one active supervisor, an active co-supervisor, or the other way around. And then the second thing is they are doing this study locally. You may find that study has not necessarily been done under local conditions. Maybe a similar study, but we've got different populations here. Were affected by many socio-economic factors. So the reason for doing a literature review is that we want to see what other people have done concerning the topic or related to the topic. It may not necessarily be the same thing. You may actually be the first person doing that study. You find that in the literature you don't get it. That's why you need to go. Now we do literature on the first world, do literature on the developing world, and then do literature review on underdeveloped world. So it sort of gives you a balance, especially in your discussion. You'll have a lot of things to discuss if you do a literature review following that principle. The study may not be the same. I mean, South Africa and we're a developing country, we are a mixture of a first world and a third world. So I still feel that there's a lot of data, there's still a lot of studies that can be done in this country that other people don't know. I mean, we read about TB from an American textbook, but TB is very common here. We should be leading those discussions. So literature review is the main thing.
Thank you so much for that, Prof. And that actually segues us very nicely into what the topic of our next MMED Mastering Your MMED series will be, which will be on the importance of publication. It's very important not just to do the research, but to put it out there for other researchers. So our topic next month will be preparing your submission manuscript and publishing your research. Date will be confirmed probably the first week, Thursday in the first week of October. I also implore colleagues to go to the SAMA website where there'll be able to be a recording of this webinar. It's also available on YouTube. With that, I see we've reached 7 o'clock. I would like to sincerely thank Prof. Steven Machica, Dr. Tijo Murar, who's a colleague I know from undergrad. It's very good to see her again. And I wish you all a very good night. Thank you for joining us. We'll see you on the next one. Goodbye.
Thank you. Thank you.
Thank you. Take care.